Hello everyone and welcome to our module on the nephritic syndrome. Shown on this slide is a concept map of what leads to the signs and symptoms of the nephritic syndrome. And the fundamental problem in the kidneys in patients with the nephritic syndrome is that the filtration barrier in the glomerulus is lost. This allows things into the urine that shouldn't normally be there, things like red blood cells and protein. And this is different from the nephrotic syndrome. In the nephrotic syndrome, only protein is allowed into the urine, not cells. But in nephritic syndrome, cells and protein both spill into the urine. So because cells can get into the urine in nephritic syndrome, red cells find their way into the nephron, and as they move through the tubules of the nephron, they can become misshapen. This is referred to as dysmorphic red cells, and they can also form casts. And you can see dysmorphic red cells and red blood cell casts in the urine of patients who have the nephritic syndrome. These patients also develop proteinuria, and when there's proteinuria, there's low capillary hydrostatic pressure. And this allows fluid to leak out of capillaries into tissues, and that contributes to the formation of edema, which can occur in the nephritic syndrome. Also in nephritic syndrome, because the filtration system of the kidneys is not working, there's a fall in the GFR overall, and this can lead to rising BUN and creatinine, and therefore glomerulonephritis or the nephritic syndrome is one of the many causes of acute renal failure with an acute rise in BUN and creatinine. If the fall in GFR is significant, it can lead to decreased urine production, which is oliguria or even rarely anuria. And then when you're not filtering water and sodium normally, there's a rise in hydrostatic pressure. Basically, there's more fluid filling up the vessels of the body. This can lead to hypertension, and this can also contribute to fluid leaving the capillaries for the tissues and causing edema. So on this slide, I've summarized the main clinical features of patients that present with the nephritic syndrome. First of all, these patients will have hematuria, and they will often complain of dark urine. When you examine the urine under the microscope, you can see dysmorphic red cells or red blood cell casts, and this is an example of a red blood cell cast on the screen here. The BUN and creatinine can rise, and therefore the patient can develop acute renal failure. There's usually hypertension present. There's usually swelling and edema. Many patients are fatigued, especially if they have a high BUN and creatinine. This is a symptom of uremia. And then finally, there's protein in the urine, but the amount of protein is usually less than 3.5 grams per day. More than 3.5 grams per day is a lot of protein in the urine, and that's usually seen in the nephrotic syndrome. In nephritic syndrome, although there is proteinuria, it's usually below the nephrotic range. On this slide, I've listed the major causes of nephritic syndrome, and we'll go through most of these in this video. Cause number 4 is rapidly progressive glomerulonephritis, or RPGN. There are many causes of RPGN, and therefore I talk about this in a separate video. But in any patient presenting with hematuria and red blood cell cast, one of the things you have to consider is that RPGN could be causing the nephritic syndrome. And then this last cause here, membranoproliferative glomerulonephritis, really can cause a mixed picture with some features of nephritic syndrome and some features of nephrotic syndrome. And I talk about this in the video on nephrotic syndrome. I won't talk about it here. Before we get into specific causes of the nephritic syndrome, let me make a couple of general points. First of all, the diagnosis is usually suggested by urinalysis. A patient who complains of hematuria, if you do a urinalysis and you see red blood cell casts and dysmorphic red cells and proteinuria, that indicates a glomerular source of bleeding, and that usually means the patient has the nephritic syndrome. You can also check the serum BUN and creatinine, which are often up in patients who have the nephritic syndrome, and therefore in any patient with acute renal failure, nephritic syndrome is one of the causes, and you always look at a urinalysis to see if they have evidence of glomerular bleeding. The definitive diagnosis usually requires a renal biopsy. This allows you to look at the glomeruli under the microscope, and you can see features of one of those specific disorders that I mentioned on the last slide, one of the disorders we'll go through in the remainder of this video. For the hypertension and proteinuria of the nephritic syndrome, most patients are treated with an ACE inhibitor or an angiotensin receptor blocker. That's because these drugs lower the blood pressure, and they also are protective against kidney damage in patients who have proteinuria. And most of the causes of nephritic syndrome are inflammatory disorders. That's why it's called nephritis, meaning inflammation of the nephrons. And therefore the treatment is usually with some form of immunosuppression. It could be glucocorticoids, it could be cyclophosphamide, it could be mycophenolate. But the bottom line is to suppress the inflammation in the glomerulus, and therefore limit the clinical features of the nephritic syndrome and also limit the renal failure that could progress to become severe renal failure. Our first cause of the nephritic syndrome is post-infectious glomerulonephritis. This is a classic cause of the nephritic syndrome. This usually follows a group A beta hemolytic strep infection. It can be in the skin in the form of impetigo, but it's often in the form of pharyngitis in the throat. In patients with one of these strep infections, immune complexes form and deposit in the kidneys. Immune complexes are antibodies bound to antigen, and they can accumulate in the kidneys and lead to inflammation and nephritis. In terms of diagnosis, biopsy is the most accurate test, but it's rarely done in the modern era. That's because there are two other tests that very strongly support this diagnosis and make the biopsy unnecessary. The first one is the presence of anti-streptolysin O antibodies. Streptolysin O is produced by streptococcal bacteria, and it's partly responsible for the lysis of cells that those bacteria cause. That's why it's called streptolysin. And our immune system produces antibodies to streptolysin O that are present for several weeks or months following an infection. So in a patient who has glomerulonephritis and the anti-streptolysin O antibody level is elevated, that strongly suggests that that patient has post-infectious glomerulonephritis. The other finding that supports the diagnosis of post-infectious GN is hypocomplementemia. This disorder consumes complement proteins in the nephron, and therefore the complement levels will get low. So if you have hypocomplementemia together with anti-streptolysin O antibodies, then you can make a presumptive diagnosis of post-infectious glomerulonephritis. Hypocomplementemia also occurs in lupus nephritis and in membranoproliferative glomerulonephritis, but neither of these disorders cause anti-streptolysin O antibodies to be elevated. Post-infectious GN is common in children, although it can also occur in adults. But the classic case you should be able to recognize for your boards is a child who develops the nephritic syndrome about 2 to 3 weeks after a strep throat infection. It takes about 2 to 3 weeks for glomerular disease to develop following a strep throat because it takes time for those antibody levels to rise. As I said before, renal biopsies are not often done in the modern era, but I'll go through the expected findings so you know what they are. Under light microscopy in the glomeruli, what you see are enlarged hypercellular glomeruli. If you look at the left, this is normal glomerulus. On the right is one from a patient with post-infectious glomerulonephritis. Note how it's just more densely packed with cells. That's really the easiest thing to recognize if you're not a trained pathologist. And when you see it all densely packed with cells like this, that's what's typical for post-infectious GN. There are antibodies and immune complexes that accumulate beneath the endothelial cells in the glomerular capillaries. And if you use immunofluorescent staining, you can identify their presence. In immunofluorescent staining, fluorescent antibodies are added to a biopsy sample, and if the target of those antibodies is present, then the biopsy sample will light up. So in post-infectious GN, if you use fluorescent antibodies for IgG or C3, the biopsy sample will light up like what you see on the screen here. And that's because there's lots of IgG and C3 in the glomeruli of affected patients. The pattern of immunofluorescence you see is referred to as granular. That's because the IgG and C3 is sort of randomly dispersed around the glomeruli, so you see this lumpy, bumpy light up pattern like what I've shown in the slide here. And then finally, on electron microscopy, the classic finding is a subepithelial hump. This is one shown on the screen here. What this dark thing is in the middle of the picture is a collection of immune complexes. There's lots of IgG and C3 in there, and that forms this hump that you can see beneath the podocytes, the epithelial cells on the podocyte side of the basement membrane. There's no specific therapy for post-infectious glomerulonephritis. The care is supportive, and most cases spontaneously resolve. Children in particular have an excellent prognosis, and almost all of them recover completely. The prognosis in adults is not as good, about 60% recover, but many of these patients develop chronic renal insufficiency, and this can occur as late as 10 to 40 years after the initial illness. And then another thing you should know is that a subset of patients with post-infectious glomerulonephritis develop rapidly progressive glomerulonephritis. I talk about this in a separate video, but it's a very rapidly progressive form of inflammation in the nephron, and it can lead to acute renal failure and even death. Most patients who have post-infectious GN do not develop this, but if a patient has a severe case with a rapid rise in BUN and creatinine, those are patients that are sometimes sent for biopsy because you have to establish whether or not, instead of just post-infectious GN, they also have RPGN. Our next cause of nephritic syndrome that we'll discuss is IgA nephropathy, also known as Buerger's disease. This is the most common form of glomerulonephritis in the developed world. So in developing countries, there's lots of strep throats that go untreated, so those countries get higher rates of post-infectious GN. But in developed countries, there's usually treatment for strep throats, so post-infectious GN is uncommon, and in those places, IgA nephropathy is the most common cause of nephritic syndrome. The hallmark of this disorder is repeated episodes of hematuria. These patients usually do not develop elevated BUN and creatinine, but they have episodes of hematuria and dysmorphic red cells and red blood cell casts that come and go over their lifetime, and in about half of patients, this eventually leads to end-stage renal disease requiring hemodialysis. The problem in IgA nephropathy is an overactive immune system. These patients make excess IgA in response to triggers. Classic triggers are respiratory infection or GI infection, and following one of these triggers, there are IgA immune complexes which form, and they deposit in the glomerulus and cause glomerular injury. The diagnosis is made by renal biopsy and immunofluorescent staining for IgA. If you add fluorescent antibodies that light up when they bind IgA to a renal biopsy sample of a patient with IgA nephropathy, it will look like this. It will light up with this granular pattern, and that's because there are IgA immune complexes deposited throughout the glomerulus. So the classic case of IgA nephropathy that you should be able to recognize for your boards is a patient with recurrent episodes of hematuria since childhood, and the episodes usually follow days after an upper respiratory infection or a diarrheal illness. And the days after is very important because that's how you distinguish IgA nephropathy from other causes of nephritic syndrome. We've already talked about post-streptococcal glomerulonephritis. That occurs weeks after an infection like an upper respiratory infection, not days. IgA nephropathy is days after an infection. And then in the video on nephrotic syndrome, I talk about minimal change disease. That also follows an upper respiratory infection. It usually occurs in children, but that leads to the nephrotic syndrome, not to hematuria and the nephritic syndrome. To make the diagnosis, as I said before, renal biopsy is usually done. It requires immunofluorescent staining for IgA. You can measure the serum IgA levels. They're increased in about half of patients, but this is not sensitive or specific enough for diagnosis. There are no treatments that have been shown to reverse the course of disease. Glucocorticoids are tried in patients with lots of proteinuria because these patients are at high risk for developing chronic kidney disease. But other than that, there really aren't any proven treatments. And the prognosis is that patients will develop recurrent episodes and often develop persistent proteinuria. And as I said before, about half of patients are going to progress to end-stage renal disease and hemodialysis. This usually takes 20 to 25 years, but many patients are diagnosed at a young age, and this means that at some point in their life they are going to need to go on dialysis. There is a vasculitis syndrome called Hinoch-Schönlein purpura, and you should be aware that this vasculitis syndrome is simply IgA nephropathy plus extrarenal involvement. HSP is the most common childhood form of systemic vasculitis. Affected children develop palpable purpura of the buttocks and legs on the skin. This is a picture of a child with palpable purpura on the legs. In the GI tract, these patients develop abdominal pain and melena, and they can also develop joint pains. And the problem is that there is diffuse IgA deposition throughout the body, not just in the kidneys like in Buerger's disease. And the diagnosis is made through a tissue biopsy, and all you need to do is demonstrate that IgA is present, and then you've made the diagnosis of HSP. Our next cause of the nephritic syndrome is diffuse proliferative glomerulonephritis. This is a form of the nephritic syndrome that occurs in patients who have lupus. It's the most common subtype of lupus renal disease. It's referred to as type 4 lupus nephritis. And it often presents with other lupus features like fever, rash, and arthritis. This is a picture of a woman with the lupus malar rash on the screen here. And so what this means is that any patient that presents with renal failure and hematuria and evidence of the nephritic syndrome, you need to consider that that patient could have lupus. Lupus is caused by immune complex deposition throughout the body, so diffuse proliferative glomerulonephritis is caused by immune complex deposition in the glomeruli. The immune complexes accumulate in the glomeruli and the nephron, and that leads to an inflammatory response in the nephritic syndrome. There are 5 subtypes of kidney disease that patients with lupus get. Type 1 and type 2 are relatively mild. Most patients with lupus who develop renal failure have either type 3 or type 4 lupus nephritis. And in both of these disorders, there's proliferation of cells in the glomeruli. We'll see a picture of that in a minute. And the urine is nephritic, meaning there is evidence of red cells and red cell casts and things like that. The only difference between type 3 and type 4 is that type 3 is a focal process in the kidneys, whereas type 4 is diffuse. And then just an aside here, but type 5 is an uncommon presentation of lupus kidney disease, but type 5 is membranous nephropathy, and this is a presentation of the nephrotic syndrome. And so when patients with lupus present with the nephrotic syndrome, this is usually the form of kidney disease that they have. So back to our discussion of diffuse proliferative glomerulonephritis. It's called diffuse because more than 50% of the glomeruli in a renal biopsy are affected. And it's called proliferative because there's an increase in the cellularity of the glomeruli. In other words, there's proliferation of mesangial cells and endothelial cells. There's also infiltration of the kidney by monocytes and neutrophils. So lupus is an immune complex disorder where antibodies bound to double-stranded DNA circulate and deposit in the skin and the joints and the kidneys. And in the nephron, they deposit beneath the endothelial cells in the glomerular capillaries, and this drives the immune response. So beneath the endothelial cells of the capillaries, you can find anti-double-stranded DNA antibodies. These antibodies drive the consumption of complement, so these patients also have hypocomplementemia, just like patients with post-streptococcal GN and MPGN. Interpretation of renal biopsies in patients with lupus is a very advanced subject, but you should be aware that the classic finding on light microscopy in a patient with DPGN who has lupus is thickening of the capillary loops. This is also called wire looping. If you look at this biopsy example on the screen here, you can see that the walls of these capillary loops are very thickened. This is a really thick one here too. That's the wire looping of DPGN in lupus nephritis. Because this is an immune complex disorder, you can use immunofluorescent staining to identify the presence of immune complexes in the kidneys. Basically, immunofluorescence is very useful anytime immune complexes are depositing in the kidneys. That could be in post-streptococcal GN, that could be in IgA nephropathy. It's also true in diffuse proliferative glomerulonephritis. You will see a granular pattern of immunofluorescent staining when you use antibodies that light up if they bind just about anything in the immune system. This is called full house immunofluorescence. You can use fluorescent antibodies and identify IgG, IgA, IgM, C3, C1q. All of these things are embedded within the glomeruli, and you can make them light up if you use immunofluorescent staining of a renal biopsy sample. Patients with DPGN present with the usual elements of the nephritic syndrome. They will have hematuria, they will have reduced GFR with a rise in the BUN and creatinine, and they often have heavy proteinuria. Sometimes it's even in the nephrotic range. And this is a severe renal disorder. It often leads to end-stage renal disease and hemodialysis. And for this reason, immunosuppression is used to try and dampen down the inflammation in the kidneys. Patients are usually treated with glucocorticoids plus cyclophosphamide, or sometimes mycophenolate is used. The last cause of nephritic syndrome that we'll discuss in this video is Alport syndrome, which is also called hereditary nephritis. And it's called hereditary because it's a genetic disorder that involves mutations in one of the genes that are important for forming type 4 collagen. Children born with this disorder have mutations in genes that code for either alpha-3, alpha-4, or alpha-5 chains that are important for synthesizing type 4 collagen. And type 4 collagen is an important component of the basement membranes, especially in the kidneys, the eyes, and the ears. It's an X-linked disorder, so it occurs in boys, and the clinical presentation is a triad of hematuria from renal involvement. These patients will have evidence of the nephritic syndrome, things like red blood cell CAS and dysmorphic red cells. There's also hearing loss from ear involvement and ocular disturbances because of collagen problems in the eyes. So this is a very rare disorder, but in terms of board questions, you want to look for a child who has this triad of clinical features and a family history of either kidney, hearing, or eye disease. And there are no specific treatments available, and affected children usually go on to end-stage renal disease and dialysis, or because they are young, they are usually good candidates for kidney transplant. And that concludes our module on nephritic syndrome.